bloating and gasiness, and pain which improves with a bowel movement. Diarrhea improves with Loperamide, taken up to twice a day, but seems to worsen his problems with pain and bloating. He's limiting dairy. He tried limiting dairy for 2 weeks, but it didn't seem to help very much with his symptoms. And he has mild tenderness in the left lower quadrant on physical examination. Otherwise, his exam's normal. So Michael has a number of questions, typical questions that all of our patients ask us in clinic. Do I need a colonoscopy? What kind of test do I need? What's causing my symptoms, and what can I do for my symptoms? So let's go to our first polling question. Which laboratory study would you recommend for a patient like Michael? Choice 1, erythrocyte sedimentation rate, or ESR. Choice 2, serum lipase. Choice 3, celiac serologies. Choice D, food allergy testing. Or choice E, I don't know. What do you think? All right, so this is a very enlightened audience. 81% choosing celiac serologies. Amy, what do you think? Do you agree with that?
I think we all recognize that his symptoms are chronic, and that the abdominal pain, bloating, and diarrhea certainly could potentially be celiac disease, which we wouldn't want to miss. It's good to recognize that that no one chose the ESR, which has less sensitivity for, if we were wanting to rule out anything like inflammatory bowel disease. He's not describing any upper abdominal pain. It's not acute, where we would be concerned for pancreatitis. He is not having any food allergy symptoms, tongue swelling, hives, to suggest that this could be a food allergy. And, with the 14% I don't know, we'll have an opportunity to learn on the upcoming slides.
All righty, very good. Let's go ahead and move on. And we'll start with talking about diagnosis of IBS. So Lynn, why don't you go ahead and get us oriented in this discussion, talking about prevalence and burden of illness.
So I'm sure most of you know that, or all of you know that IBS is a really common condition. It has a worldwide prevalence. The prevalence can change based on the diagnostic criteria. In general, whether you're using Rome 3 or Rome 4 diagnostic criteria, the prevalence is between 4 and 11%. And you can see this map of the different prevalences in the different areas of the world, and that's based on the Rome 4 criteria. But it is the bread and butter of GI. It's also the 7th most common diagnosis seen by primary care physicians. We have 3 different bowel habit subtypes: IBS with constipation, IBS with diarrhea, and IBS with mixed bowel habits, which is diarrhea and constipation.
I'm sorry about that. We'll go back.
Yeah, I was gonna make the point that 2/3 of individuals with IBS symptoms experience symptoms for at least a year before they actually seek health care. Many individuals with IBS don't seek health care, so it takes a while to make the diagnosis. They can have symptoms for 7 years or even more. And it does impact their quality of life. It can be associated with school absences and decreased work productivity. So this is the Rome 4 criteria for IBS. This came out in 2016. Now, the frequency of the abdominal pain is based on over 90% threshold of the US general population on abdominal pain frequency. So the criteria was designed this iteration, to be more precise and specific for IBS because it's being used in clinical trials. So the patients have to have the presence of recurrent abdominal pain at least 1 day per week in the last 3 months, because we're looking for active symptoms associated with 2 or more of the 3 following features: related to defecation, which means the pain could get better or worse after a bowel movement. It has to be associated with a change in stool frequency and a change in stool form. They just have to meet 2 out of the 3. And we want the criteria asks that the patients have symptoms at least 6 months ago, but they're active for the last 3 months, because we're looking for chronicity. And the IBS diarrhea subtype is all based on stool form, which we are going to go over in just a minute. So I think we can probably show the next slide, because I think that illustrates what we use in clinic and in clinical trials, which is the Bristol Stool Form Scale. I'm sure many of you are familiar with this. It's on coffee mugs and T-shirts and birthday cakes. So it's something that's very, very common. But this is a nice validated instrument because it actually correlates with gastrointestinal transit time, with colon transit time. So we have type 1 through type 7. It's validated based on the words, the text. The pictures add, some confirmation, but type 1 or type 2 stools are the hard, drier stools, associated with slower transit time. So if IBS constipation patients have at least 25% of their bowel movements, now this is without medication, are type 1 or type 2, and less than 25% are type 6 or 7, which is the loose watery stools. That's the diarrhea type associated with more rapid transit. IBS diarrhea is the opposite, so at least 25% of bowel movements are loose watery, and less than 25% are the hard, dry type 1, type 2 stools. IBS mix means that the patient will report that at least 25% of their bowel movements are type 1 or 2, and at least 25% of their bowel movements are type 6, 7.
Hey, Lynn, everybody likes an algorithm, right?
Yeah.
And I think the Rome Foundation has developed some algorithms. You want to walk us through this?
Yeah, so the algorithms always start with symptoms because that's what the patient is coming into the healthcare provider office for. So for the diagnostic algorithm for IBS, the patients are reporting recurrent abdominal pain that's associated with defecation and or disordered bowel habits, so diarrhea, constipation, or both. So we always do a medical history, of course, includes a psychosocial, dietary history, medication history. We do a physical examination. It's helpful to do a digital rectal examination, even though I know in studies it's shown that healthcare providers are doing it less and less. GIs are doing it more than the other types of healthcare providers. But it's always important to ask about alarm features because the alarm features is where it helps to determine what path diagnostically you're going to take. If a patient has alarm features, which is unintentional weight loss, bloody stools, nocturnal diarrhea, family history of celiac disease, colon cancer, inflammatory bowel disease, you're probably going to be a little more aggressive in your diagnostic workup depending on what they're reporting. But if they don't have alarm features, which many of these patients don't, we do limited screening tests, which we'll go over in a minute. And this is supported by scientific evidence. If you find an abnormality, then you would do more specific evaluations depending on what you find. But if you don't find anything, or if they have no abnormality on this limited diagnostic testing, then you can diagnose them with IBS if they have the symptom criteria. And then you determine what bowel habit subtype based on the Bristol Stool Form Scale. So in a very more simplified algorithm, you see their symptom presentation, you rule out alarm features, and if they're present, you do diagnostic testing based on what they're reporting. So it's appropriate for what their symptoms are. And then if they don't have any alarm features, then you can do very minimal or limited diagnostic testing. So the AGA, ACG, and other GI societies have reviewed the literature, and they have come up with their guidelines on the diagnostic testing for IBS. And these two tables are really based on very recent evidence and these guidelines. So if you see on the left side, these are the tests that are recommended. And the first one is really more of an approach, that we can make a positive diagnostic strategy versus excluding multiple different diseases before we make that diagnosis of IBS. If they have the symptoms and you've done some limited testing and they're negative, you can make that positive diagnosis. Now, IBS with diarrhea group has a wider differential diagnosis, so it's been recommended to measure celiac serologies, which many of you got correct on the answer, fecal calprotectin or fecal lactoferrin, and basically looking for inflammation in the GI tract. And then a C-reactive protein, again, looking for an inflammatory condition like inflammatory bowel disease. Now, there's a little bit of disagreement on bile acid diarrhea testing, but we know that there's about 25% in the literature of patients with chronic diarrhea or IBS with diarrhea can have bile acid diarrhea, which would be a different treatment approach. In those patients where you're suspecting it, maybe in a patient, say, who has had a cholecystectomy, you can do some testing like fecal bile acids, but you can't just empirically treat them as well. If Giardia is endemic, like it is in the United States, it is recommended based on the guidelines to do Giardia testing. And in patients, for the more constipated patients, where you're suspecting that they have pelvic floor dysfunction, they have refractory constipation symptoms, it is recommended to refer the patient to anal-rectal physiologic testing, like anal-rectal manometry or balloon expulsion tests. Now, on the right side, the red light is where you see it's not recommended. It's not recommended to do routine stool testing unless there is something in the history that's suggesting they could have an infection, like maybe they traveled to a certain location. It is not recommended to do a routine colonoscopy under the age of 45. You would do routine colonoscopy screening just like you do in the general population. Food allergy or food insensitivity testing currently is not recommended based on the evidence. And it is also not recommended to routinely do a breath test, a lactulose or a glucose hydrogen breath test.
So Amy, can you lead us through the barriers, the challenges that we all face when we're confronted with a patient with suspected IBS?
Of course. I think Lynn already described that it takes up to 7 years on average for a patient to be diagnosed and confirmed to have IBS as their diagnosis. And so why is it taking that long for these patients to get diagnosed? I think one issue is initiating that conversation with the patient. It takes a lot of time to talk to the patient and get a good, thorough history of their GI symptoms. And as we know, a lot of providers, clinics are super busy and are not able to invest potentially the time. There's also the lack of clinician understanding of the criteria for diagnosis, which we just reviewed. And so then this diagnosis becomes this, diagnosis of exclusion, where patients are getting that multi-million-dollar workup. They're getting their gallbladders removed. They're getting, repeated colonoscopies. They're going to the emergency room and getting CT scans because they're concerned that there is an organic underlying condition. And there's apprehension is coming from the patient asking for additional testing, and then the clinician not feeling confident in exactly what's going on. But remember, if we're sticking to that realm for criteria, ruling out those alarming features, we can make that confident diagnosis and be able to initiate an appropriate management plan for the patient.
Lynn, Amy alluded to this, and you talked about it too, the use of that term, making a positive diagnosis. What do you mean by that?
Yes, there's actually studies to support this. A positive diagnostic strategy means that the patient meets the symptom-based diagnostic criteria for IBS, and that you have done the limited diagnostic testing, like a complete blood count, making sure they're not anemic, the celiac serologies, fecal calprotectin. And if that's negative, you can actually make that diagnosis of IBS. You don't have to do an exhaustive workup. Particularly, you might be thinking about this a little bit on the younger population, but definitely, and patients without alarm features. So definitely you can make that positive diagnostic strategy. And then, studies have shown that when healthcare providers talk to patients who have these functional GI disorders like IBS, or what we call now disorders of gut-brain interaction, we tend to use more vague terms. You may have this, it doesn't look like it shows that. And sometimes the patients are not really, it's not resonating, or they really are understanding what their actual diagnosis is. So sometimes they leave and say, was never really given a diagnosis. And then they find that healthcare providers, when they're seeing patients with like inflammatory bowel disease or these structural or anatomic disorders, that more definitive words are used. So it is, I would encourage everyone to start, if you're confident about that diagnosis, that you use more definitive terms. It's also helpful to explain the pathophysiologic mechanisms so the patients understand why are they having symptoms. Because they'll say, well, all my tests are normal, why do I have these symptoms? And it's very helpful to explain, well, there's studies that have shown that the colonic motility is more hyperresponsive, in particular after meals. And that's why you may have, that's why you are having, not why you may have, abdominal pain, loose stools, bloating after meals. That there's evidence of visceral hypersensitivity that leads to a reporting of abdominal pain, discomfort, bloating. And you really want to validate the patient's symptoms, that they're real symptoms. And even though our routine testing can't measure these pathophysiologic mechanisms, they've just been studied in many, many research studies, but they do explain their symptoms.
Lynn, I think you raised a whole bunch of really important points there, but One of the ones that I think that really bears reemphasis is the language that you use.
Yeah.
You know, patients pick up in 2 seconds whether or not you feel confident about the diagnosis that you rendered. And that influences their confidence in what you're recommending to them, both in terms of treatment and in terms of their confidence in you. So thinking about and using language that provides your level of confidence, hopefully you feel confident about your diagnosis, is really important. Remember that exhaustive testing as well implies a lack of confidence in your diagnosis, and in addition to tremendously driving up cost. And at the end of the day, an earlier diagnosis leads to earlier treatment. You know, I'm really struck by numerous studies, which have been alluded to, that show that patients with IBS symptoms take years to get to a diagnosis. And you wonder what's happening to those patients as they're sort of trying to find their way in terms of understanding what their condition is.
Bill, can I add another thing? So it's not
Sure.
also just the way we talk to the patient. So Doug Drossman and Johanna Ruddy wrote a book recently on gut feelings, the patient stories, and I was reading them, and one struck me because the patient wrote the story of how she saw her physician looking increasingly anxious and frustrated with the repeated negative tests. Yeah. And the patient herself was already, I can't remember if it was a male or female patient, but remembered already feeling a little anxiety themselves, unsure what the diagnosis was. But actually seeing the doctor feel that way raised their anxiety more. So they're not only listening to what we're saying, they're watching the way we're responding and the way we're handling the diagnostic approach, and it affects them.
You know, it raises a really interesting point. You published that study a number of years ago, you and your colleagues at UCLA, showing that patients were not with IBS symptoms were not necessarily reassured by a negative colonoscopy, and you wonder how much of that result was related to the actual colonoscopy being normal, not being reassuring, or how much of it was related to exactly what you just alluded to, which is the way the physician communicated that result to the patient.
It's also exhausting for the doctor, and I think they feel drained when they're ordering multiple tests. They keep coming back, it's negative, they're struggling for another test. So it's also not helpful for them. But they showed it, I remember, in a fibromyalgia study, which has some overlap with IBS, that the more tests you give, the more frustrated the patient got, and the more they expected that you were missing something, because it kept expecting that if we're ordering another test, we must be thinking we're missing something.
Right, right. Yeah, and I mean, I think that's absolutely true. So let's talk through a couple of special considerations in regards to this case. So first thing is, this patient clearly identified an episode of quote-unquote food poisoning that preceded the onset of their symptoms. So tell us what you think about that. Would you communicate the diagnosis, or does that have any implications that matter from the patient's perspective?
I think the patient always wants to know why they got the condition. So what are the factors that increase the risk of getting that? And they will understand that if they get a gastroenteritis, and even though the infection has cleared, they still have symptoms, that's a really known entity, because the infection can lead to some dysregulation in gut function and brain-gut axis, where they have these symptoms of post-infection IBS. I think the other important point is that post-infection IBS doesn't necessarily have the same natural history as the regular IBS, where you get that not related to an infection. And so they've had studies that have followed patients out for a long period of time and find that with time, the IBS prevalence goes down. Now, the one infection, because you can get any different type of infection and it could be associated with post-infection IBS. But what's interesting is that they showed in a study with Giardia that post-infection IBS actually lasted longer. Now, some of the other symptoms they got, like chronic fatigue, got better, but the IBS symptoms actually stayed longer, more prevalent than with a bacterial infection. And I was thinking, why is that happening? And I was thinking that maybe it's because Giardia is not self-limited. You actually have to get diagnosed and get treated. Or bacterial infections can be self-limited. And so it might be longer. They may be dealing with these off-and-on symptoms. It may take longer. We know that the more severe and prolonged the illness is, the infection, the more likely they're going to get post-infection IBS. I have no idea if that's the reason, but I thought that was interesting.
Okay, so the second one is a really easy question, right? So when do you order breath testing in SIBO? I know that at the meeting there was a whole debate on this today. Lynn, give us a brief answer on what you think about this. I know that you also did a session on this just the other day as well, right?
Yes, I debated the great Mark Pimentel.
Yeah.
It was very exciting. No, so we have a little bit difference of opinion. What I always say to people is that you should really look at the data, and you should decide yourself whether or not you want to order breath testing for SIBO. And there's been ACG clinical guidelines on SIBO and also AGA clinical practice update, and I would encourage people to read it. In general, for me, I don't normally order breath testing. If I'm going to treat them for their IBS symptoms, I personally think that there are patients who have, and studies have shown that if there's a negative breath test, they can still respond. So if I'm going to treat them anyways, and if it's negative, am I going to say I'm not going to treat them? And if it's positive, I'm going to treat them anyways. So that's for me. But I can see in some situations where you may want to do breath testing.
Hey, Amy, so how would your diagnostic approach change if you had a patient with more constipation-related symptoms? Obviously, we talked more about the diarrhea-predominant patient, but how about the constipation patient?
For the, if the patient's coming in with constipation, I'm less concerned for more of that, inflammatory, really not like inflammatory bowel disease. 15% of patients with celiac disease could present with constipation, but the guidelines currently don't really support testing for celiac disease. So if a patient's coming in with, this chronic abdominal pain associated with constipation, I think really you can focus more on starting, one, making sure you get a CBC, make sure they're not anemic. They don't need a colonoscopy unless they're due. And at that point, you really can initiate treatment for them and see how they respond. I think it's also very important that you ask those additional questions that may support, an underlying pelvic floor dysfunction, that like dysenergic defecation. We also know that over 30 to 50% of patients with IBS with constipation could already have that as an overlapping condition, and make that decision maybe earlier in the algorithm if you did want to do any type of pelvic floor testing, like with an anorectal manometry and balloon expulsion testing to further support pelvic floor dysfunction.
And this is a question actually online that came in. And the other thing is, don't forget, digital rectal examination is very helpful as a screening test for dysenergic defecation and fecal incontinence. So don't forget about your digital rectal exam.
Especially if you don't have as much access to manometry testing, such as at Northwestern, where we have that. And of course, a digital rectal exam should be done whether you're in a university setting or community setting. All
right, let's summarize our first section here. So most patients require limited diagnostic investigation, and of course a lack of alarm features is associated with a lower pretest probability of organic disease. Celiac serologies should be done in patients with IBS-D and IBS-M. A fecal calprotectin and or a serum CRP can help to rule out IBD in patients with IBS symptoms and no alarm features. Additional diagnostics can be ordered in the setting of persistent or changing symptomatology. Okay, so before we move on to our second learning objective, let's look at another case. This case is Yvonne S., a 44-year-old female who complains of crampy abdominal discomfort most days, and this has been ongoing for several years. She reports abdominal pain, which has caused her to miss part or full days of work as an event planner. She's missed more than six times in the past 3 months. She reports passing spontaneous bowel movements about 2 to 3 times per week. And she's currently using polyethylene glycol, 17 grams twice a day, in addition to soluble fiber. She uses dicyclamine, 10 milligrams, as needed for abdominal pain. And without the PEG and fiber, her stool frequency is actually even worse, 1 to 2 times per week. In terms of a more focused history, she reports that her stools are hard, a 1 to 2 on the Bristol stool form scale, denies the use of manual maneuvers to facilitate defecation, and reports straining with roughly half of her bowel movements. Past medical history is remarkable for hypertension and migraines. no family history of gastrointestinal disease or GI or ovarian malignancy. She smokes a quarter pack of cigarettes per day and has cut back recently. She underwent a colonoscopy less than 2 years ago, which was fortunately normal. And she also underwent a non-contrast abdominal CT scan from an emergency room visit 3 months ago, which actually showed moderate stool burden, but was otherwise unremarkable. So here are some common questions that patients like Yvonne would want you to address. What prescription medications can I try? What diet changes can I try? And also, can I stop taking my medications, PEG and fiber, if she started on a prescription medication? So let's go to our next ARS question for all of you. Which of the following treatment strategies would most improve symptoms of abdominal pain and constipation for Yvonne? Choice 1, start tigacerod 6 milligrams twice daily. Choice 2, increase PEG to 3 times daily. Choice 3, start linaclotide 290 micrograms daily. Choice 4, start amitriptyline 10 milligrams at bedtime. Or choice 5, I don't know. All right, so 75% choosing linaclotide. Lynn, can you briefly tell us whether you agree or disagree?
Yeah, I definitely agree. Linaclotide has been shown to be highly effective for patients, for symptoms not just of constipation, but abdominal pain. And that was some part of the issue. So I definitely think at that dose, that's indicated by the FDA and other regulatory agencies for IBS with constipation. So I think it's a good choice.
And Amy, we touched on the fact that these patients commonly want to know about non-medical treatment alternatives, like diet, for example. So can you lead us through a discussion about the low FODMAP diet?
I would be happy to, and I could spend all evening talking with you about diet. What I do want to emphasize is that the low FODMAP diet is not designed to be for all of your patients. I know dietary counseling and interventions takes time, but I've seen providers just hand a patient some information on the low FODMAP diet. But this is a very complex dietary intervention that requires detailed counseling by a dietitian and a significant investment of the patient. I think it's also very important that the provider recognizes does the patient have irritable bowel syndrome with diarrhea? Does the patient have IBS with constipation? Is there a significant abdominal bloating component? And based off of the subtype is really where you can kind of cater the type of dietary intervention that you're going to choose for them. Furthermore, if they have a lot of already perseveration on their diet, if they're already underweight, if they have a history of disordered eating behaviors or avoidant restrictive food intake disorder, the low FODMAP diet may not be the appropriate choice for this patient. They also need to be in the right stage of change to be able to really invest their time into this diet. So what is the low FODMAP diet? Well, it stands for fructooligodimonosaccharides and polyols. And what these are short-chain carbohydrates that are poorly absorbed in the gut, resulting in that osmotic diarrhea, fermentation by the gut bacteria, leading to bloating, gas, abdominal symptoms. So for a patient that has potentially already tried a lactose-free diet or a gas bloating diet where they've eliminated just the garlic and onions and just trying to eat more consistently and are still maybe having those symptoms and are interested in this diet, then maybe that's the right patient. So this diet requires them to eliminate these food groups from their diet and restrict all of them for 4 to 6 weeks with a plan to reintroduce each type of low FODMAP back into the diet over the upcoming 6 to 10 weeks. So we can see which foods of the low FODMAP diet are actively triggering their symptoms. And then at that point, it's designed to be personalized. So this can be a less restrictive diet that has more longevity for them. Because how restrictive this is could lead to other health implications and isolation because they're not able to socialize or be able to enjoy their food.
Very good. And Lynn, we also saw from those questions that patients are oftentimes really interested in OTC medication for lots of reasons, right? So tell us about the OTC options for patients with IBS.
Well, there's evidence that soluble fiber can be efficacious in treating IBS symptoms, and there's studies where they had all different bowel habit subtypes. It's usually more recommended for the IBS with constipation patients. Peppermint oil basically works as an antispasmodic, and there's a number of studies that support its use to treating and relieving global symptoms of IBS. I think it's very useful for postprandial symptoms, just like other antispasmodics. Polyethylene glycol is, I think, the most commonly used over-the-counter agent for children and adults with constipation. There's not much data in IBS-C, but in general can help the constipation symptoms, of course, but it hasn't been shown to reduce abdominal pain or bloating in the limited data that's available. You know, many patients will use probiotics, but there was an AGA guideline that was fairly recent that showed, looking at the evidence for probiotics in IBS, that it's not recommended based on the available evidence, that if it's used in IBS, it should be studied in a research trial. So in general, it's not recommended. I know patients will take it, and sometimes they have some improvement, but that's based on the guidelines. So this is the quality of evidence for IBS with diarrhea, and this table is set up for the type of medication and the AGA and the ACG guidelines. So the AGA had pharmacotherapy for IBS guidelines in 2014. Some of the agents were just carried forward to the current guideline that's going to be published in the next month or two, and some of them are new. Antispasmodics was reviewed in 2014, and you can see the recommendation and the quality of evidence in the different columns, and then just some comments. So the AGA and ACG have a difference of opinion on recommendation. The AGA had a conditional recommendation. There's conditional and strong. Conditional means that there could be future evidence that could change the recommendation or the certainty of evidence. Strong means that it's unlikely to do that. The quality of evidence for antispasmodics is low, but the ACG felt that they had a conditional recommendation against antispasmodics. They thought that the data was older, had poor quality. Peppermint oil, though, was recommended by the ACG. The AGA didn't really separate out antispasmodics and peppermint oil. But there was a conditional recommendation, although there is a low quality of evidence. Tricyclic antidepressants, which we really try to use the term neuromodulators, because that's how we're using it in IBS. Both the AGA and ACG recommended it, but the AGA gave it a conditional recommendation, low quality of evidence. ACG gave it a strong recommendation, moderate quality of evidence, and it's recommended to start at a lower dose and then move up the dose to the lowest, most effective dose, best tolerated dose. And bile acid sequestrants, the ACG had a conditional recommendation against using that in IBS diarrhea. The quality of evidence was very low, and felt like there needed to be more rigorous randomized control trials, which is true, and that testing for bile acid diarrhea is limited. But you can think about, testing or treating it if you really suspect it.
Yeah, I think I'm going to try to put this in perspective because Lynn helped to author the AGA guidelines. I helped author the ACG guidelines. And, a question you might ask is why is it that for some of these things, the organizations have come to different conclusions? And it's because a lot of this has to do with the philosophy of the committees going in terms of how the recommendations were made. So specifically, the ACG looked at it like, do these treatments offer benefits for the global symptoms, abdominal pain, and altered bowel habits for the specific subgroup of IBS for which the medication is intended? And if it did not address the global symptoms, it was not recommended. And that's why, for example, antispasmodics got a conditional recommendation against, is because while they help with abdominal pain, they don't consistently help with bowel habits. Bile acid sequestrants help with diarrhea, but don't necessarily help with abdominal pain. On the other hand, the AGA took a much more practical approach, which is, would you use these things related to the fact that they do offer efficacy for certain symptoms? They are relatively inexpensive and safe. So it's actually not that these things are so different. If you read the actual text in the guidelines, they're not actually that different. But it's the approach that each organization took to these guidelines, just to help you to put
I mean,
it in
I think
perspective.
guidelines are really important. We're both involved in guidelines, but you don't want to live and die by them. You want to still be clinically practical and look at the factors of the patient and what they've been through and decide if it's reasonable to use them, you know, in particular patients.
So here's an example of what I was talking about, Loperamide. AGA made a very practical recommendation, which is a conditional recommendation, because it's reasonable to start with Loperamide in your patients with IBS-D, but Loperamide is unlikely to do very much for abdominal pain or urgency. And so for that reason, the ACG recommended against Loperamide as an evidence-based treatment for IBS-D. You can see that there was really pretty good symmetry between Rifaximin, Alosatron, and Eluxadeline. So let's go through some of these treatments in a little bit more detail. First, talking about Rifaximin, and I think you all know that Rifaximin is a broad-spectrum, non-absorbable oral antibiotic. It's FDA approved for patients with IBS-D in the United States at a dosage of 550 milligrams 3 times a day for 14 days, and the FDA approval also allows for up to 2 retreatments in patients that develop recurrent symptoms. It improves global symptoms in patients with IBS, which is why it's been recommended by both organizations. And it also improves gas, bloating, and abdominal pain. There is some data that suggests that a positive breath test, the data right now is for lactulose, but we're actually going to be presenting some data in the near future on glucose, that a positive breath test identifies patients with IBS-D who are more likely to improve with Rifaximin. Actually, the likelihood ratio is 2 to 3 times more likely to respond to Rifaximin with a positive breath test. Eluxadeline is a mixed mu kappa opioid receptor agonist and a delta antagonist. It's FDA approved for IBS-D at a dosage of 75 or 100 milligrams taken twice daily with meals. The most common side effect in association with Eluxadeline is constipation, but the one that everybody needs to be aware of, the two, are one, sphincter of Oddi dysfunction, and also acute pancreatitis. And for this reason, although those AEs are quite rare, this drug is contraindicated in individuals who have previously undergone a cholecystectomy, have any history of significant biliary disease or pancreaticobiliary disease, and also those individuals who are consuming more than 3 alcoholic beverages per day. In those settings, you should not use Eluxadeline. Alosatron is an oftentimes overlooked but very effective drug, a 5-HT3 receptor antagonist, FDA approved in a pretty narrow indication. Women with severe IBS-D who have failed to improve with traditional therapy. The starting dosage is 0.5 milligrams taken twice daily, and it may be increased up to 1 milligram taken twice daily. Now, related to rare events of ischemic colitis and dose-dependent constipation, there's actually a REMS program which is necessary, so a risk management program which is necessary if you prescribe Alosatron. It's pretty simple to use, but it does require some education and also signing a consent form. Now, I'm going to turn it to Amy to talk about the data for IBS-C.
Thank you, Bill. So we'll transition now to talking about the recommendations by the ACG and AGA for IBS with constipation. And again, the recommendations are based off of not only their response for the constipation, but the abdominal symptoms as well. So when we look at the over-the-counters, the soluble fiber and the polyethylene glycol, maybe there is less, it may not treat all of the global symptoms compared to the FDA approved medications with C-lower. Soluble fiber in particular, psyllium, is a really great water-soluble fiber that bulks up the stool, is minimally absorbed by the gut bacteria, and can be a great place to start for patients that are looking for something more natural and over-the-counter. Polyethylene glycol is extremely effective for constipation. We can give it to children and pregnant women, and it's very, very good at softening the stool by drawing more water in. But the reason that it got a conditional, like the ACG conditional recommendation against its use is one, there's a low quality of evidence to support that it can impact and treat the global IBS symptoms, and in fact can actually make the bloating and abdominal symptoms worse. So if a patient is wanting to try it, first, it's obviously very cheap. There's no harm in starting there. But if it's not treating their global symptoms of the abdominal pain, then at that point, I would recommend you transition to one of the FDA-approved therapies for IBS with constipation, which are listed here. Lubiprostone, Linocletide, Plecanatide, Tigacerod, and Tinaponor. And we will be, I'll be reviewing these individually on the upcoming slides.
Excellent.
So Lubiprostone, it was the first secretagogue to come out on the market around 2007. So there's 3 secretagogues. There's the Lubiprostone, the Linocletide, and the Plecanatide. And they are all, very effective for IBS with constipation, overall very safe with minimal, if any, systemic absorption. So can be prescribed with confidence for a majority of your patients. So Lubiprostone, it works by GI targeting the bicyclic functional fatty acid, and it selectively activates the type 2 chloride channels, which then enhances intestinal fluid secretion. So there's 2 doses of Lubiprostone. There's the 8 microgram dose and the 24 microgram dose. The 8 microgram dose is the IBS-C FDA-approved dose, whereas the 24 microgram dose is the CIC FDA-approved dose. It's dosed twice daily, and it's best taken with meals. It's best to take it with meals because the main side effect of Lubiprostone is nausea, which can be mitigated by taking it with food. Now, for Lubiprostone, for IBS in particular, it is only approved in adult women, whereas in CIC, the 24 microgram dose is approved for adult women and adult men. So the second secretagogue to come on the market, I think that was around 2012, is Linocletide. It's one of 2 guanylate cyclase C agonists, the other being Plecanatide that we'll talk about next. So both of these work by targeting this GCC receptor that then starts to cascade to release cyclic GMP. Cyclic GMP is supposed to release extracellularly, and animal models have shown that that may reduce the visceral afferent firing of the neurons and thus reduce abdominal pain. And that studies have shown with Linocletide's use, which we'll look at as the next slide a little bit more on how it can reduce those abdominal symptoms over the course of 6 to 8 weeks of use. So sorry.
Sorry about that. Oops.
So Linocletide for IBS with constipation is FDA approved at the 200 microgram dose, and it's dosed daily. It's best to take at least 30 minutes before the first meal of the day to potentially help mitigate that primary side effect of diarrhea. Linocletide also comes in 2 additional doses, 72 microgram and a 145 microgram, and those doses are FDA approved for CIC. So the main side effect is diarrhea at 20% compared to 3% in placebo, but you will see that severe diarrhea is only 2% compared to 1% in placebo.
Hey, Lynn, can you talk us through this? Because there's been a lot made about the role of GCC agonists for abdominal symptoms, like abdominal pain, abdominal discomfort, bloating. And you guys published this study, which specifically addresses that. So can you lead us through this?
Yeah, so prior to this study, the FDA did not feel that there was any primary endpoint or patient-reported outcome measure that was developed according to proper guidance that they had for a patient-reported outcome measure. So they have been using the interim endpoint of a reduction of abdominal pain and improvement in stool consistency or frequency, depending on what subtype you're talking about. But this took a lot of effort, as a collective effort, where IBS endpoint was determined following the FDA PRO guidance for IBS. And this main endpoint is about it's an abdominal score. And it's a 0 to 10 scale, so it's 11 points, very similar to what we use for abdominal pain. And it's comprised of abdominal discomfort, abdominal bloating, and abdominal pain. And they really correlate very highly together. So what this study showed that Linocletide can improve the abdominal score compared to placebo. And you can see the change, the improvement of 1.9 on a scale of 0 to 10 versus placebo 1.2. So it's just the average of all of them. But if you look individually, abdominal discomfort, abdominal bloating, and abdominal pain, Linocletide improved these abdominal symptoms compared to placebo in a statistically significant manner. So that's why, bloating, the FDA has always said there's no bloating endpoint that has been developed properly according to their guidance, but this is included in that type of PRO that is now, I think, accepted by the FDA.
Excellent, thank you.
It's just a reminder that these like the GCC agonists are really designed for patients that are perseverating and maybe they're presenting more with bloating and less on the constipation symptoms, that these could still be a really good therapy to offer them. So Plecanatide is the second GCC agonist. It is a uroguanylin analog. And so what that means is like when we eat food, we stimulate uroguanylin to promote fluid secretion and secondary motility. The uroguanylin is more pH selective for the small bowel and has less affinity for the colon. And therefore, this is thought to reduce the side effect of diarrhea. And as you can see, for Plecanatide, diarrhea rates are around 5% compared to 1%. Plecanatide comes in one dose, 3 milligrams, which makes it easier for the provider if they're questioning if their patient, has IBS with constipation or CIC. And what we're learning maybe is that the two conditions are kind of along the same spectrum too. So it's an easy medication to prescribe. Furthermore, you don't have to dose it around eating. You can take it with or without food, which makes administration of the medication a little easier for the patient. Tinaponor has recently become FDA approved and on the market. For some providers, they think maybe this is that fourth secretagogue, but it's actually considered its own class. It's called a sodium hydrogen exchanger isoform type 3. So instead of secreting fluid and electrolytes into the lumen of the bowel, it's blocking reabsorption of sodium and this secondary fluid. So for some, it's considered a retainer of the sodium. Because it's retaining the sodium, it's best to take about immediately before meals. Larger meals, you're going to have more efficacy, especially if it's a larger meal with more sodium intake. So it's dosed, and it's only approved for IBS with constipation and not CIC. It's dosed at 50 milligrams twice a day, immediately before those meals. The data as far as the efficacy and safety profile would be similar to the secretagogues. The most common side effect is diarrhea at 16% compared to 4% in placebo. The last medication I'll discuss for IBS with constipation is ticagrelor. It is a 5-HT4 receptor agonist. It works specifically for that type 4 serotonin receptor that lines the gut. We know there's serotonin receptors throughout our entire body, but it has affinity specifically for that type 4 serotonin receptor. You may know that there's another 5-HT4 receptor agonist as well. That's called Prucalopride. That medication is only approved for CIC and thus is not part of our presentation this evening. Tegaserod had been on the market maybe 10 plus years ago. Some of your older patients or older providers may recall prescribing it and the patients having a good response to it. It was taken off the market for questionable risk cardiovascular events, but had been used in Europe. And then it was brought back and FDA approved back in the US more recently with more stringent criteria. So it's only approved for IBS with constipation in women. And these women have to be less than 65 years old and have no history of any cardiovascular ischemic events and not more than one cardiovascular risk factor. And when you take into account this criteria, the risks for a cardiovascular event is basically 0 and consistent with placebo. For Tegaserod, specifically for IBS-C, it's dosed at 6 milligrams twice per day, taken at least 30 minutes before meals. The main side effect that patients can have with those 5-HT4 agonists, especially when I see in clinic, is a headache. They'll describe, a transient headache that I counsel those patients can be responsive to acetaminophen. These patients may also describe some abdominal pain or diarrhea.
Thanks, Amy. And in regards to those of us that are old enough to remember Tegaserod, can you, rather than referring to us as older, maybe refer to us as more experienced?
Wiser, yeah.
All right, so let's go back to our case. So Yvonne returns after trialing linaclotide 290 micrograms daily for 10 weeks and discontinuing PEG. She has not identified any food-related triggers. She reports bowel movement frequency of 3 to 4 bowel movements per week. Most bowel movements are complete, and she reports significant improvement in straining. She has less bloating and pain, but still has some symptoms 1 to 2 days per week, especially when she's working more or getting less sleep. She's begun avoiding all social activities outside of work because she's worried that her symptoms will interfere with these activities, and it's easier to just stay home and deal with her pain. So our next ARS question for everybody, what would be the next step for Yvonne? Choice 1, discontinue linaclotide and start Tegaserod. Choice 2, continue linaclotide and start PEG. Choice 3, continue linaclotide and add Lubiprostone. Choice 4, consider behavioral therapy. Choice 5, I don't know. All right, again, a very enlightened audience. Lynn, you're going to lead us through the next part of this discussion. Let's move on for the sake of time here. There's been a whole bunch of questions actually coming in online about behavioral therapies, so perfect time for us to go ahead and discuss it. What do you think?
Yeah, there's been actually a couple of reviews, one of that Bill co-authored, about what is now termed brain-gut behavior therapy. That's a new term, BGBT. This first slide, I think, is a nice one because it's really important for all of us to realize who is the right patient to refer for a brain-gut behavior therapy and who's inappropriate. So if we look at the green light, yellow light, red light, I'm gonna start with the green light. Who are the good candidates to refer for behavioral therapy? And it's individuals who accept their diagnosis that there's a disorder of brain-gut behavior. They understand the role of these brain-gut behavior therapies and how they can relieve their symptoms, and that it's part of the integrated care. It could be combined with pharmacotherapy or diet, but it's just one of the treatments that are instituted in their management. They agree that coping could be improved. The behavior therapy is basically giving them a skill set to have greater control over their symptoms. And they have the time to invest in this. This takes time. It takes some effort, homework to improve their symptoms. And then this also is patients who experience isolation, avoidance. They have significant stress or distress around their GI symptoms. They have GI symptom-related anxiety or stress. Now, potentially appropriate, that's a yellow light. People with disordered eating, motivational deficits, personality features impacting care, PTSD, or psychological comorbidities. Now, some of these patients are already receiving some management that's addressing that from a different healthcare provider, and they may at the same time do well with behavior therapy. But that's really focusing, the brain gut behavior therapy is really focusing on their GI symptoms. So if they need behavioral therapy for non-GI symptoms, then they may be either have to simultaneously get that treatment or get that treatment first and then get a brain gut behavior therapy for their GI symptoms after. Now, inappropriate candidates, and our GI health psychologists have definitely educated us about this, but patients with uncontrolled or severe psychopathology, active substance use, patients that are overly focused on a cure, and need case management services. They don't really accept or have insight on the brain-gut association with this condition, or they can't invest the time in behavior therapy. I've definitely referred patients and then they'll cancel and they don't really keep up. And because this takes time, it's going to be multiple sessions and it takes effort. But the nice thing about behavior therapy is it can give them this skill set that can help them long term and potentially eventually get them off pharmacotherapy or over-the-counter remedies, and that's why it's useful. And it could even help their other non-GI symptoms, because behavioral therapy has been effective for different conditions. This is a nice figure because it shows along the brain-gut axis that you can have these centrally mediated processes that enhance the bothersomeness of and amplify symptoms, maladaptive behavioral responses, overactive emotional response, stress sensitivity, and GI motor dysfunction, and leads to what you can see on the white boxes of hyperalgesia, avoidance, hypervigilance, pain catastrophizing, fear of the symptoms. They're attentive, very attentive to their symptoms, very focused on it. They have more of a fight or flight, sympathetic response, and a visceral hypersensitivity. And you can see the different types of behavior therapy like gut-directed hypnotherapy, cognitive behavioral therapy, mindfulness-based stress reduction, relaxation training. It targets the different outcomes or the characteristics that the patient reports. But you can see many of them hit multiple targets. The gut-directed hypnotherapy is really more of a acceptance, a more passive approach. The cognitive behavioral therapy is more active approach. It's really good for patients with catastrophizing behavior. And so our GI psychologists will sometimes start hypnotherapy first and then move to cognitive behavioral therapy because it gets them in a better frame of reference to do the cognitive behavioral therapy.
Very good. Amy, so Lynn's done a great job reviewing behavioral therapies, but we can do this with medications as well. So how about neuromodulators? What do you think?
Yes, I think neuromodulators certainly have a place for the right patient that you're seeing. And before, a lot of us would just be, instead of using the term neuromodulators, using the term, tricyclic and antidepressants, which has a negative connotation for our patients. They hear an antidepressant, well, I'm not using that. I'm not depressed. I'm not anxious. Why do I need that medication? And therefore, by changing and shifting the terminology to describe it as a neuromodulator, that we're focusing and honing in specifically on the pain component, those abdominal symptoms that they're describing, and that there's a lot of good data to support their use in patients with IBS and specifically those abdominal symptoms. So when we look at a large meta-analysis of 16 randomized controlled trials, we know that the most data is going to be on the TCAs. And this can reduce those global IBS symptoms and specifically that abdominal pain. TCAs are really good for abdominal pain. They also have those anticholinergic properties. So for a patient that has IBS with diarrhea, it may help potentially slow down some of the motility and help with some of the diarrheal component of their symptoms. And depending on the patient, there's a variety of different TCAs that you could consider for them. There are TCAs that have more anticholinergic properties like amitriptyline. Nortriptyline may have a little bit less, and then there's desipramine that may have even less as far as those sedating properties for the patient. For the TCAs, if a patient's already on, if they're a mood stabilizing medication and they're stable on it, it's okay to still layer on a neuromodulator for them. It's just you would start at a low dose. For TCA, it's 10 milligrams. It's best taken before bed, again, because of the sedating side effects. And we want them, in my practice, we typically have them on the 10 milligrams for a couple weeks just to make sure that they tolerate it, and then increase them up to the 25 milligram. Certainly, it's very important to counsel your patient that this is not a short-term medication, that it takes commitment to the therapy, and that they may not see those responses for 8 to 12 weeks on the therapy. So I see patients that are quick to stop it and then jump to the next one because of a quick side effect, or they don't feel like it's working. Other neuromodulators or medications to consider to help with their IBS symptoms. There is some studies to support SSRIs, but they're not going to be as good for those abdominal symptoms. When I would choose an SSRI for a patient is when there's a significant anxiety component to their symptoms or overlapping depression, where maybe that is really what's driving their symptoms. And we need to get them on and address the anxiety component, potentially in conjunction with behavioral therapy or other types of counseling that's focused more on the anxiety piece of their global symptoms. SNRIs, really, we don't have good data yet to support their use, but when we look at other chronic pain conditions such as fibromyalgia, we know that like duloxetine can be effective, and so that's another therapy that you could consider for the right patient that may have some overlapping other chronic pain conditions.
Excellent. Lynn, this meeting has been transformative in a way because we've been talking more and more about digital health solutions. And so what do you think about digital health solutions? Give us some insight based on what's on the slide.
Yeah, this is probably just some of the ones that are out there that we had. But what you see on the left side is symptom tracking apps. So patients can enter their daily symptoms, and then you'll be able to see over time what's been happening with the symptoms, which can be very useful, especially when you're trying to institute a therapeutic intervention. So it's Dieta, GI Health, Bowel, and they can also share them with their healthcare provider as well. There's also digital therapeutic apps for these brain-gut behavior therapies. Mahana is an FDA-approved app for cognitive behavioral therapy for IBS. So it's actually been shown in a study to be efficacious. Zemity is another app. It's not FDA approved. It's for cognitive behavioral therapy. It offers cognitive behavioral therapy as well. Regulora and Nerva are gut-directed hypnotherapy apps. The Regulora was recently FDA approved. So the FDA approved apps will require a prescription. The other ones are not. It will come with a lower cost, but they're apps that you can download. There's also dietary resources. These are a lot of times focused on FODMAP, but it's helpful for patients because they're not really sure if a food that they're eating is a high FODMAP food or a low FODMAP food. There's also the Monash FODMAP app that's been available for a long time. I like that app because it'll show that the quantity. So there could be a certain fruit or vegetable that a very low amount is a low FODMAP. But if you raise the amount, it becomes a high FODMAP. So you want to take that into account on the amount that they're eating. So that's kind of nice too. There's also additional resources.
The Rome Foundation and the International Foundation for Gastrointestinal Disorders, or IFFGD, these are both well-known, long-standing organizations that provide education. So the Rome Foundation has educational information on their website. There's a lot of books. There's also videos. And they will give videos like on communication or certain particular settings, like a patient who keeps wanting a CT scan. And then how would you do that? So it's role playing, and you could look at these short videos to try to give you some education or information that might be helpful to you as you're communicating with your patient. The IFFGD is really focused on giving information to patients, and Bill and I have been very actively involved in their publications library for all different questions. And this is really using expert opinion, scientific evidence to give information to patients on many, many different topics. So there's a lot of resources also on our GI Society websites, but there's a lot of resources. But these particular use expert input and based on scientific evidence.
Excellent. Let's go ahead and close the loop on our patients, Michael and Yvonne. So for Michael, he's diagnosed with IBS and diarrhea. It's likely post-infection IBSD. He's advised to take Loperamide 4 milligrams as needed instead of daily for work and social situations as it worsens his pain and bloating. He takes Rifaximin, 550 milligrams 3 times a day for 14 days. There's an improvement in symptoms, but and no repeat course is needed, at least to the point of follow-up. Stool studies are negative for bacterial infection. For Yvonne, she's diagnosed with IBS and constipation. She enjoys significant improvement with Linocletide. She's expressed interest in psychotherapy and discussed options, and she opted to try a CBT mobile application. She still would like to quit smoking, but is concerned about it causing constipation. So here are our SMART goals, the specific, measurable, attainable, relevant, and timely goals for tonight's discussion. We want to confidently diagnose IBS utilizing symptom-based criteria like the Rome criteria and excluding red flags or alarm features and using limited diagnostic tests. We want to utilize a combination of evidence-based treatments, including over-the-counter remedies, dietary interventions, and prescription medications to manage patients' overall IBS symptoms. We want to identify patients who will benefit from behavioral therapy, and Lynn did a nice job of summarizing the factors that predict a patient who's more likely to respond to behavioral therapy. And then finally, ask patients about their priorities of care when developing a treatment plan for IBS. So meeting the patient halfway. All right, so to ask a question, we've actually already received quite a few questions, but you can keep submitting your comments and questions by clicking on the Ask Questions tab. You can also tweet to @CME Outfitters. If you have colleagues who missed tonight's live program, this activity will be available on Gastroenterology Hub on the CME Outfitters website, which also has additional resources for both clinicians and patients. I'd like to thank my colleagues who joined me on the stage tonight, Lynn as well as Amy. I'd also like to thank CME Outfitters for their assistance in developing today's program. And don't forget to receive CME or CE credit for tonight's program. Complete the post-test and evaluation. Thank you to our audience for participating and for providing the best care for our patients with IBS. So I think we'll go to our Q&A session now. We have a lot of questions. So first question, I'll ask Lynn. Lynn, what do you think about Colace for IBS-C? We strategically avoided that particular medication. Do you have an opinion on Colace?
So Colace or Docosade has not been studied in IBS with constipation. And there's also a recent review by Darren Brenner and I think Satish Rao on over-the-counter remedies for chronic idiopathic constipation. And there's there's not really data to even study Docosade in chronic idiopathic constipation. So in general, it's not recommended. I think it probably has a little effect, if I'm going to say from an anecdotal standpoint, but in general, if you're going to treat constipation, there are a lot better remedies than that.
Yeah, I think it's useless. I wouldn't use it. That's my honest, unvarnished opinion on cholates for constipation and IBS-C. What do you think, Amy, what do you think about this issue of smoking? You know, that one particular patient, Yvonne, was worried about stopping smoking and what effect that might have on her constipation. Do you counsel folks in regards to smoking?
Well, when I have a patient that's, smoking, certainly I look at the bigger picture, what are they struggling as far as stopping smoking, and why are they continuing to smoke? Is there a large anxiety component? Are they doing it for weight maintenance? Have they tried to quit and they can't? So it's a conversation that, I emphasize is obviously important for them to stop for not only their overall health, but, other risk factors such as colon cancer, esophageal cancer, stomach cancer. So when it comes to IBS, I do think it's important that they're in the right place and frame of mind to stop quitting. For our patient, it sounds like we've really made a lot of progress in treating her constipation piece of her symptoms and in making progress with the abdominal symptoms. She was interested in, behavioral therapy, and I think once she's able to get those additional resources and feels really good as far as her IBS control and gets a little more confidence, that would be the appropriate time for her to stop smoking.
Great. Lynn, an interesting question from the audience, and that is about COVID and GI symptoms. I know that the Rome Foundation lecture this year was on COVID and GI symptoms, and I know you moderated that. Can you provide a brief summary, about what's been observed?
Yes. So you can have GI symptoms with active COVID. I'm sorry that I can't remember the exact percentage. It was like 25%. I can't really recall. But there are a group of patients that get long COVID symptoms, including GI symptoms. Having GI symptoms, interestingly, during COVID does not predict getting long COVID GI symptoms. And there's a lot of different data about it. One study that Giovanni Barbara was doing prospectively, I think PPIs and having allergies, I can't remember the other risk factors, but there may have been anxiety. It is a risk factor to get post-COVID IBS-like symptoms. I really think when looking at the literature that post-COVID IBS is very similar, or DGBI, is very similar to post-infection IBS. However, the post-infection IBS is really more about having GI symptoms and a gastroenteritis, where COVID is a systemic infection that can target the GI tract, but really the symptoms come from having an enhanced immune system. Yeah. And so that's really what's causing the symptoms, and it's not only isolated the GI tract. So I think what he found is the post-COVID IBS was about 4%, as opposed to what you see in post-infection IBS. That prevalence is more like 10%. It's probably because it's a different type of infection.
I think people forget that, though, is that there are papers, they're a little bit older now, showing that not only GI infections can lead to IBS. There are actually papers published showing that any systemic infection in a susceptible individual can lead to the development of IBS. And I think it underscores exactly the point that you made, which is that it's certainly more likely to ramp up the gut immune system with a GI infection, but it's not the only way to ramp up the gut immune system. So I think that's a fascinating topic, actually.
Yeah, the other speaker was Sarah Ballou, and she was making the point about the psychological effects and how that can influence having GI symptoms and actually recovering from COVID. It's interesting because there's some conflicting data, but it probably depends on a lot of factors, that how much that patient is impacted emotionally, financially, by other family members, their job, school, educating their children. But it did show that women are more impacted than men. And it might have been because of what, women experience. That might be different than men during COVID.
While we're on the infection topic, there's an interesting question here, and that's, in the day of GI, or in the age of GI PCR, and pretty much everybody gets a GI PCR nowadays, we're picking up blastocystis. Is there any association, this is for either one of you guys, whoever feels comfortable with this, is there any association with blastocystis and IBS?
I don't think so. I mean, in general, you would think about treating it if the patient has diarrhea, right? If they have symptoms. Normally, you wouldn't do that. I don't recall seeing a study with that in IBS, per se.
The time I've had diagnosed a patient with it, they were having diarrheal symptoms and actually did respond to treatment and made significant improvements. So that's a patient, lost to follow-up, and I presume is not having ongoing IBS-like symptoms, but didn't have IBS symptoms for years. It was something more, I wouldn't say acute, but maybe more subacute presentation.
Yeah, so I think, I don't think we know the answer to this. I think it's reasonable to say that if you incidentally pick up blastocystis and the patient doesn't have diarrhea, you probably don't need to treat it. But on the other hand, I think it's not unreasonable to treat blastocystis in a patient that has diarrhea.
And maybe the treatment, if it wasn't even, it may not even have been what we were actually treating, if there was an overlapping, SIBO or other, like an IBS presentation that we were treating, that they actually made improvements from the antibiotic.
And digital rectal examination, there's a couple questions in here about, like, we alluded to that, but we didn't talk about, what you focus on or what you do. Lynn, you want to talk us through a digital rectal examination in patients with constipation?
I know it's your favorite topic.
It is my favorite
I know
topic.
you want to hear me say it, so I will. So it really is important. It's particularly important in constipation and fecal incontinence. Definitely think so. But I always explain what I'm going to do, because I'm standing behind the patient, so I always explain what I'm going to do. But they get on the left lateral decubitus position. You can, before you start, just have them bear down so you could get a feel for their pelvic floor movement. Sometimes their buttocks actually increase and they actually ascend, which means they're squeezing instead of relaxing. A lot of times it's hard to do because they're probably worried about passing stool or gas. And then you just gently put in your finger, but I always do it on the side and then move it in rather than sticking straight in. And you normally just stop for a moment where you're feeling the external anal sphincter and internal anal sphincter, and then you put your finger all the way in, and with the tip of your finger is really feeling the puborectalis muscle, which is the muscle that starts at the pubic bone, and it's a sling-like muscle that wraps around the rectum and creates this anal rectal angle about 90 degrees at rest. And it's a somatic muscle, so it's under our voluntary control, and it's contiguous with the external anal sphincter. So you feel that, and you ask the patient first to squeeze, which they can do, and sometimes you have to try to get them to really focus on just squeeze their anal sphincter, not their entire body. So sometimes they need some coaching, but you're looking for the tone and the pressure with squeeze. And then you ask them to bear down, to push out like they're sitting on a toilet, evacuating, and I put my left hand on their abdomen. I have my right finger in the rectum, and what I'm feeling on my left hand is, are they contracting their abdominal wall muscles when they're pushing out, which is the proper way to do it. And then in your finger, what you're feeling is relaxation, which is hard if you really think about it. You have to contract your abdominal wall muscles and relax your pelvic floor and anal sphincter muscles. In fecal incontinence, you have to squeeze your anal sphincter muscles, but you have to relax your abdominal wall muscles. So that's kind of something harder to do. So you're really looking for relaxation. If you find paradoxical pelvic floor contraction, that means they're squeezing when they're supposed to be relaxing when they're bear down. So we call it PPFC. And some patients just don't relax. Sometimes I coach them a little bit just to make sure, because it's kind of hard to do that in that kind of setting. Now, if it's normal, there's a very low likelihood that they have pelvic floor dyssynergia. If it's positive, like they contract when they're supposed to relax, that could just be because of the setting. You don't really know if they have dyssynergic defecation, but you are going to refer those patients for anorectal manometry and balloon expulsion test.
Yeah, I completely agree with all that. It's an interesting thing, though, because obviously if you're in a setting where you don't have anorectal manometry, I agree with you that the greatest value of digital rectal examination is in its negative predictive value.
Right.
The positive predictive value is less consistent, but that said, it's not bad. And so if you're in a setting where you don't have anorectal manometry and you find obvious dyssynergia on your digital rectal examination, I think you should just refer the patient to physical therapy and biofeedback training. Amy, I got a really interesting question here, and that is, given your background as a dietitian, does that change your view or approach, do you think, in regards to when to recommend diet therapy?
Well, I think most patients are going to need some dietary intervention. I think most patients have already tried and attempted dietary interventions before they are seeking help. So for a majority of my patients, at the right time, obviously getting a diagnosis and discussing treatment interventions can be quite overwhelming. There's a lot of options. It's a collaborative discussion as far as where they feel they want to start with their management plan. But at the right time, whether it's maybe it's not that first visit, or it might be subsequent visits if they're still having the abdominal symptoms, for example, despite treatment of the constipation or the diarrheal piece, then I certainly want to have that conversation about diet and discuss with them their options. I would say a majority, though, of patients are asking me what they've tried. What do you think? I feel so much better on a gluten-free diet. Is that fine to continue? That's a big one. And one, we don't have really good data to support a gluten-free diet in IBS, and I am concerned about patients that are on a very restrictive diet when on gluten, their celiac serologies were normal. But if there are fructans in gluten, and that's part of the low FODMAP diet. You think of foods that have gluten and having a lot more preservatives or additives to it. So this overall might be a more healthier diet and a more mindful diet. But for example, for that type of patient, I would counsel them on that and maybe focus more on a low gluten diet instead of being extremely restrictive. So I really cater my dietary counseling to what the patients are already tried, what their health literacy is. But I would say for a majority of patients that have abdominal IBS symptoms, they've already intervened on their own. And at that point, we have to work together to cater and make sure what they're doing is correct and in a healthy manner.
Hey, Lynn, a question here has to do with why are some of these medications only FDA approved for women?
Well, it started with Alosatron, but most IBS and constipation trials are predominantly women. So you have a smaller number of men in these trials. Sometimes when they analyze the data, they separate the men and women, and sometimes you don't get a significant effect in men, but it could be due to the small sample size, like with Alosatron. It actually worked in men in a controlled trial, but if you look at the initial data when they first did an FDA approval, they had less men, and when they separated out by gender, it was only effective in women, not in men. So they started realizing that IBS is a female-predominant disorder, that maybe there is a differential type of treatment response between men and women. But I think the approval was really based on that there was definitive evidence that it was effective in women, statistically, but not in men.
Yeah.
I think more and more what we're seeing as we move along is it's really being approved in both. Mm-hmm. But predominantly more women do these trials than men.
Yeah, although, don't you think there is biologic plausibility that there might be differences?
Oh, definitely.
Yeah.
Men and women?
Yeah.
Oh, yeah. I mean, that's one of the areas that I study. There's a lot of differences between men and women. There hasn't been as much data on treatment response, sex differences in treatment response, as there has been by looking at, motility or transit or visceral hypersensitivity or brain imaging.
Yeah, interesting. I'll take this next question, which is Tinaponor seeking approval for hyperphosphatemia. Any need to monitor phosphate levels in patients who don't have end-stage renal disease? And the answer is no. in the phase 3 trials, we very closely monitored phosphate levels and other electrolyte levels, and there were no significant changes, and there's no recommendation in the PI, the product insert, for monitoring of phosphate or other electrolytes. Well, we're almost out of time here. So another question, and that is the insurance issue. There's a lot of questions about whether there are any tricks that you'd recommend to help to get insurance coverage for prescription medications. I'm going to ask both of you this and see if there are any tips. Amy, you want to go first?
Yeah, I mean, for most of the FDA-approved therapies for patients with private insurance, there are savings cards that you can go to their websites and have the patient fill out and present to their pharmacist. And for a majority of insured patients that are first being prescribed a secretagogue, for example, should be able to get it covered. Now, for the newer medications, such as like the 5-HT4 agonists, for insurance to cover, typically they require trying at least one of secretagogues and some over-the-counters as well. And so it may require that they failed those in order to get it approved. So most of the time I start with the secretagogues, document in my note that they've failed them before trying, one of the newer medications. For patients with Medicaid or have Medicare where they have large deductibles, a lot of the prescription drug companies offer patient assistant programs. And so I have many of my patients that qualify for that and are able to get their medications through this patient assistant program.
Well, Lynn, do you got any comments?
Yeah, I would say that the one thing you definitely want to make sure is that you're using the right dose with the right indication. Yeah. Because that's the sure way of getting rejection. So if you're going to use 290 of Linocletide, but you associate with chronic idiopathic constipation, it could get rejected. You have to associate with IBS with constipation. And Rifaximin, you can't say the indication is SIBO. It's IBS with diarrhea. So you just have to make sure you're matching the right medication, right dose with right indication. Often you do need a prior authorization. So what I've been doing in my notes is I start saying previous medications tried and what the response is, so I keep the list so that when I ask the office to submit a prior authorization, then they'll see what they have tried. And it makes it a lot easier. The other thing, particularly with new drugs, there'll be certain like specialty pharmacies that you can send your prescription to that are very good about trying to get that coverage. And they'll even do sometimes prior authorization, so you actually fax them your last clinic note. So sometimes there are certain pharmacies that will be helpful and knowledgeable on particular agents.
Well, Lynn and Amy, thanks so much for your participation tonight. Audience, thanks so much for coming, and I hope you enjoy what there is left of DDW 2021. Thanks, 2022. Thanks very much. Have a good night.